The medical information included in this podcast is provided as an educational resource only. Please consult your healthcare provider before making any healthcare decisions.
We all need sleep. We all need sometimes things that help us function just a little bit better. And we've come a long way.
Welcome to the FabryCast, a place for conversations about Fabry disease. My name is Julia Alton, your host, advocate, and I live with Fabry disease too. This podcast is a space where we can learn from experts who are devoted towards a better future for patients. It's a place that highlights the human experience of living with Fabry, and it's a space for community, reminding us that although we're rare, we're not alone in this journey. So whether you're someone personally touched by Fabry, a caregiver, healthcare professional, or you're just curious to learn more, you're in the right place. This is episode 1 of the FabryCast, and I am honored to have a distinguished guest here with me today. She is an associate professor, genetic counselor, director of the Emory Genetic Clinical Trial Center, and she's a leader in the world for Fabry. She has also written a few Fabry children's books, but most importantly, she's deeply committed to Fabry. For those listening, you might already know we're talking about Dawn Laney. And for those of you who haven't had the pleasure of listening to her speak, you're in for a treat. So welcome, Dawn.
Thank you, Julia. I'm so excited to be on this inaugural podcast. I couldn't think of a better forum to talk about Fabry.
Well, thank you. And we couldn't think of a better person to start us off on our first episode, Fabry 101. Today we're talking about, the foundation of Fabry. Things like, what is Fabry disease? What's happening in our body? We're hearing a lot of these words, classic, non-classic, mutations. So talking about all of these things. First, I wanted to, just for anyone who's listening, let us know what your role is in the Fabry space right now.
Sure. So I would say my role is an advocate, a listener, and a connector in Fabry disease. In my daily life, I work with patients who live with Fabry disease, and I do research in Fabry disease, both my own research, and I'm a coordinator on clinical trials. And then I do a lot of education in Fabry disease, both for healthcare providers and patients themselves. I love educating and talking about Fabry disease. And that's why I'm so excited about today, because I feel like, hey, I can give you some building blocks. And then as your podcast moves on to cool, other neat topics, and if you've got the basics, you can learn and understand Fabry disease so much more easily and so much clearer. And it really helps when you're trying to talk with healthcare providers and you're trying to talk and learn about Fabry disease. So great idea to start with the basics.
Yeah, thank you. And so, I'm thinking if our listeners right now are, maybe it's a new patient, newly diagnosed, maybe it's a healthcare professional who has a patient trying to learn more, or just, any Fabry patients and caregivers or friends, just trying to really get a deeper understanding of the disease. Can you first kind of explain just what is Fabry? What is Fabry disease?
Sure. So Fabry disease is sneaky. Fabry disease is basically caused by missing an enzyme. So in every cell of our body, we have this recycling center called the lysosome. And in the lysosome, we've got a bunch of enzymes. And each of those enzymes has a big, giant molecule it's supposed to break down so you can reuse in your body or you can get rid of it. In Fabry disease, we're missing an enzyme called alpha-galactosidase A. Don't panic. You don't have to remember that. Just remember there's a missing enzyme. And when it's missing, you end up with the storage of these lipids. They're called glycolipids. They're not the lipids you eat. They have nothing to do with cholesterol. They really are just things that help us really in daily life, how our body function and grow and develop. But if you don't get rid of them and break them down, they start getting in the way. And when they get in the way, they line the blood vessels and organs in the body. They make the cells really big. They make the spaces in the blood vessels really small. And that what leads to all these problems. And the reason you don't have enough enzyme when you have Fabry disease, so if you have low levels of enzyme, is because you've got a change in your gene. You'll hear it called a mutation, you'll hear it called a change, you'll hear it called a variant. And that variant means you can't make the enzyme you need, which means back in that lysosome, you've got the storage, and that results in all the symptoms that we see in Fabry disease. The other thing about the storage is it's not just the storage that causes the problems. We've really learned that inflammation is also an issue. So your body, your immune system's like, I don't like all this storage stuff. I do not want it to be here. And so it starts to attack it, if you will. And that is inflammation. And inflammation is a problem we need to solve, as well as solving the problem of the storage when we look at thinking about treatments for Fabry disease.
That's interesting because so often I've only really heard it as being called a storage disease or a storage disorder. So that's an interesting kind of approach to now look at inflammation, some things that we can do to help that inflammation. And what are some of the symptoms there's a lot of symptoms because Fabry is a multi-systemic disorder. Which it's complex, right? And this is why I remember one of my first meetings really trying to understand, it's not just the heart and it's not just the kidneys, it's a bunch of different things going on. So what are some of those symptoms?
Yeah, so when we think about Fabry disease, we got to think about things on a spectrum, right? So you've got a range. So you've got people who are so affected, and it's called classic Fabry disease, and they start with symptoms in childhood, and then things just progress to get more symptoms and more problems after that. On the other end of the spectrum, it is still severe. It may just not begin in childhood. So the health issues start as an adult, but much younger than you'd expect to have heart problems or kidney problems or pain problems if you were in the general population. So saying all that, let's talk about the key symptoms that any healthcare provider should be like, I am very curious about possible Fabry disease if we see some of these, what I call them red flags. So if you see somebody who doesn't sweat, plus somebody who's got these interesting corneal whorls in the eye under slit lamp exam, plus if you see that when they get hot or a fever, they get burning pain in the hands and feet that's not picked up on a nerve conduction test because it's the little tiny fibers and not the big fibers that the nerve conduction test can do. And then sometimes there's these bumps. I don't call them a rash because they don't itch, but they start like around the genital area. We like to nicely call it the bathing trunk region, which is just a nice way of saying that sometimes people are going to have these reddish purple bumps around their genitals, on their lower abdomen, but they can be anywhere. So those are the first signs where you're like, maybe this person could have Fabry disease. The other things is having strokes before you're 50, having heart disease before you're 50, most arrhythmias or enlarged left bottom part of the heart, or having, like kidney problems. So if you start having proteinuria for no good reason in your 20s, that should be a clue as well. So you're kind of looking at two batches of things you can see with your eyes and things you need to see by doing some tests. But we have to remember it's a progressive disease. So if we take the classic Fabry disease and we look at what does it look like in kids. So I've been doing a lot of research into the kids who we know they have Fabry disease from the time they're born. And what we do know is that most kids with classic Fabry disease, they're going to have symptoms in childhood. They're on the more severe end of the spectrum. They have corneal whorls before they're even born. So if you were to do a slit lamp exam with your optometrist, your ophthalmologist, you can see some of that storage in their eyes, not affecting their vision. It's just there, making a pretty star pattern in the back of their eye, which is very easy to see. Now, not everybody with Fabry has that, but a lot of people do. But then the first things you start seeing in the kids is intermittent bloating and then constipation and diarrhea. And I think the biggest sign that we look for in kids as they're kind of, 5, 6, 7 years of age is if they have excruciating abdominal pain that lasts greater than 2 hours and keeps them from doing anything else. That is a big clue. But it's the progression, because you can have a kid who has those symptoms, but it's the fact they went from bloating to diarrhea to this horrible pain kind of thing that tells us that a kid may be having signs of Fabry disease. And you just see them being tired, not able to keep up with their friends. And then there's the pain. So when they play sports, when they get too hot, they get at first maybe a tingling, then a burning pain. And then I've had kids describe it as a Minecraft axe in the foot, a stabbing pain. And it may not be all the time, but I thought that was the best description,
that is good.
As you think about it. Yeah, you're like, oh yeah, that does make sense. So that's our little kids, right? And then gradually, as things go on, then we see things like protein in the urine. We see maybe a ringing in the ears. And as you get into adulthood, then you start seeing slow heartbeats, more fatigue, pain in the hands and feet, more of those bumps, You'll have hearing loss over time. You can see more headaches and what we call mini strokes, TIAs, and it just progresses on until the organs are not functioning as they should. And without treatment, then we worry about early kidney failure, early arrhythmias that are not good for your heart, and then we worry about early strokes. But we have treatments now. So what we're hoping is that with more people diagnosed, get earlier treatment, and we start avoiding all of these scary bad things we talk about when the things just keep going and we never are able to treat them.
And so if I'm a patient and maybe I'm newly diagnosed, if I'm listening thinking, do I have classic or non-classic? Mm-hmm. Is there these kind of is there something that a listener could figure out by listening?
That is a great question, Julia. And I think that it's one that's really hard to figure out. The only way we really define classic is, did you have signs like we just described in childhood? And if you're a male, is your enzyme less than about 5% of normal? But other than that, it's pretty hard to figure out how you divide it up, because some people are non-classic, but they had pain when they were in their 20s. And Some people are non-classic and all they had, they had, when they turned 30, they suddenly found that they had some arrhythmias in their heart rhythm and some enlargement of their heart that shouldn't have been there. And then they went and had a genetic panel and found that they had a gene change that causes Fabry disease. The one thing to know is that usually we can look at the gene change and predict whether it's going to be classic or non-classic, even though there's so many mutations out there that are family specific. It's not like Fabry is always caused by one mutation or one gene change. Oh no, every family gets to have their very own one. Except for there's a few mutations. For example, there's one in Taiwan that came over from a set of pirates who came and lived long and multiplied. And now we have an increased risk of later onset Fabry disease in Taiwan with this one gene change, because it came over and the population was small and the population grew and that gene kept going. But there's only a few of those. Mostly it's these family-specific mutations. And so when we're trying to decide if somebody is classic or non-classic, we start out by looking at the levels of enzyme in men, because it's a little bit more straightforward, and that gives us our first clue. And then we look at family history and we try to figure out who's having what symptoms and when they started. And then we look at the individual from head to toe and we say, okay, it looks like, when you were a child, you didn't have these pains. When you get a fever, you don't have this, and maybe you don't even have the corneal whorl. We're not saying you need to ignore your Fabry disease. In fact, non-classic Fabry disease is even sneakier, because the symptoms that come on with your heart and your kidneys, you can't feel. So a lot of people get surprised and get a new diagnosis of non-classic Fabry disease out of nowhere, it feels.
And this word de novo. So I think in Fabry, we have, if you're a female, you have a 50% chance of passing it to your son or daughter. Mm-hmm. If you're a male, you will pass it 100% chance to your daughter, but the male will not get it. Your son will not get it. What is de novo, and what does that mean?
Sure. Yeah, so what you're describing with the inheritance is because this gene, the GLA gene, that when it changes causes Fabry disease, is on the X chromosome. So as women, we have 2 X chromosomes. So one of those X chromosomes has the gene change that causes Fabry, and typically the other one doesn't. Now, there's all sorts of weird situations in life, but typically, like 99% of the time, you've got one gene change causing Fabry on one, and the other one's normal, so 50% chance you pass it on, right? Men have 1 X chromosome and 1 Y chromosome. In fact, the only reason they're biologically male is because they have this Y chromosome, and Y chromosomes have nothing to do with Fabry. So if they make a son, that nothing to do with Fabry disease chromosome gets passed on to their sons. For their daughters, there's only 1 X, so they got to pass it on. Now, that's the inheritance pattern, but it has to start somewhere. And we've found over the years that there are cases where we have an individual and we find a gene change and they definitely have Fabry disease, and then we test their parents, maybe some siblings, and they are the first one in their family. So we call that de novo. De novo is just, I believe, Latin for it's new or of the new. Yeah. Now, there is a weird thing, which is called gonadal mosaicism. And that means in your eggs and sperm, you can have a change that causes Fabry disease and not in the rest of your body. So even though sometimes we test parents and they're like, you look clear, we still would test siblings, particularly if they have symptoms, because we want to say, okay, there's not this weird, different gene changes in your body than your genital kind of thing that we need to rule out. So But we have found, at least in our population, and it may not be for everybody's population, more women who are de novo than men. And I don't know why that is. And I did try to study it once upon a time, but I am more of a clinical geneticist than one who does lab stuff. So I'm going to leave that the big brains in the lab, and hopefully they'll tell us soon why it might be that women have more gene changes that make them more de novo women with Fabry disease than men.
Interesting. How many mutations are there in Fabry, and like what number are we at now as we're learning more?
Yeah, last time I checked, it was heading towards 1,000.
Yeah.
You'll see in most literature over 800, over 900. But as we do newborn screening, and that's only in the United States, we've got a few states that do that. I don't believe there's any provinces in Canada that do it currently. Yeah.
No, not yet.
Yeah, so we're finding all sorts of new gene changes all the time. And then we have our scientists who are working to find gene changes because they want to, what we call characterize mutations, or they want to figure out if those gene changes cause disease, don't cause disease. If they cause disease, is it classic or is it non-classic? Does it reduce the enzyme and not do other things? Because one of the crazy things about Fabry disease is there are a few gene changes. One of the names, you don't have to memorize this, is D313Y. And when you look at the enzyme levels in a man, the levels are really low and it looks like they could have Fabry disease. But then when you look at the gene change and you look at their symptoms, they don't have any health problems related to Fabry disease. So we know that what we call a pseudo deficiency, which is just a really fancy way of saying there's a gene change that apparently in our test makes the enzyme look low, but when you actually look at the individual, they have the enzyme. It's just the test is not able to measure it the way that it needs to. Why? It has to do with the test itself. And it becomes really hard when you're doing newborn screening and you find children that way, because families can feel, but is this really disease causing and we just don't know it? Is it not? And that's why people look at mutations, try to figure out are there things that are bringing down the enzyme levels artificially and aren't going to cause problems. Because it can make your journey even worse if you're told that you maybe could have Fabry and you have a gene change, but it's not the one that causes problems. And I think that's where it gets really confusing.
And I think you're probably familiar, in Canada, we have one mutation that's very common on the East Coast.
Yeah.
Yeah. And I think it's often talked about in literature, but also at some of the big meetings we go to. That mutation. So how did that happen? Yeah.
You remember how in Taiwan you had the one pirate ship that came and gave everybody? Well, so in Nova Scotia, there was a woman who was from German descent, and she came and settled in Nova Scotia. And what happened is basically she had lots of children. And so, Nova Scotia was a fairly small island. And so there's a lot of people on the East Coast that have Fabry disease with this one gene change. And it's a classic one. So, it's not like it's a one that we wouldn't find, until later in life. This is one where you'd see issues in childhood. And, your amazing doctors over there are so familiar with Fabry disease because in Nova Scotia, it's pretty darn common.
Yeah, exactly. Yeah, exactly. Okay, so something that's very interesting is females. This is, there's been times where you have a family and you have two girls, and one of the daughters, could have a lot of symptoms, and the other one isn't experiencing as many symptoms. So what's going on there?
Sure. Good question. All right. Remember when the one with the two X's? Before we're born, so when the egg and sperm come together to make an individual, there's two X's that are on and they're all working. But before we're even born, in every cell, one of the X's mostly turns off. So you only have one GLA gene that's supposed to be working in one particular cell at a time. But the way that it turns off is supposed to be random. So theoretically, a woman with Fabry disease should have about 50% of the enzymes she needs in her body. But in practice, when we look, this is called X inactivation, or we call it lionization because it's a brilliant woman, Mary Lyons, with a Y, who figured it out. So if you look into a woman, you'll see there's, approximately 50%. But that doesn't mean that the cell that had one of the X's turned off in the heart is always going to be the same as their sisters. It's completely different. So you have women who have heart disease early, but maybe not kidney disease. Or you have women who have horrible gastrointestinal problems, but maybe would never get increased risk for stroke. So what you have to do with women with Fabry disease, you have to look at them from head to toe, and you have to evaluate each organ system and each learning how they're feeling every single year. or every other year, depending on what's going on. But women with Fabry disease do have symptoms. But early days, because of X inactivation, because of how geneticists thought, they told women they were unaffected carriers, which has been hard to get around, because for over 20 years now, we've known women are not unaffected carriers. They can and do have Fabry disease. And one of my missions in life has been to help women say, I am a woman with Fabry disease, as opposed to I'm just a carrier.
Yes.
Because when you're just a carrier, then you don't think you're worthy of treatment. You don't think you're worthy of care. And you're always going to put, your male relatives first. But that's not good, because if you're going to care for your male relatives and everybody else, you have to be healthy too. So I am here to say women have Fabry disease. And we have an amazing publication out with some other amazing people in Fabry disease that, lay it out very plainly and talk about symptoms that you have and how many women have these things compared to general population. I think the most amazing fact is, if you look at quality of life of women with Fabry disease compared to women with multiple sclerosis, Fabry women in many instances have worse quality of life. And nobody questions whether or not someone with multiple sclerosis needs care and treatment.
Right.
Right. So, but again, gotta look. They did a study in Spain for women who said they had Fabry disease and no symptoms. And the vast majority of them had not only subjective symptoms they just thought were normal for them, but also things they found when they did kidney biopsies or looked at their proteinuria or looked at their heart. So again, Fabry is sneaky. So women and men, we got to look real closely, and we got to look repeatedly, not just once.
And that's good to know, because, there's been situations where females are, if you're in an emergency situation and you go to the Emerge and you're saying, I have Fabry disease. And if it's a quick look at the literature, or Google search or whatever, it's hard for that physician to know, what level of Fabry disease a woman has. So I think by having these conversations and teaching women to, a little bit more about the disease and what are those things that they can say in this emergency situation, or to just help them understand the variability that females have living with Fabry.
Yeah. I think sometimes you just have to get a letter from your physician that says, this is a woman with Fabry disease. She already has low heartbeat. She has elevated troponin, like all the things that show that you really have it and that you should be treated just like they would treat a man. And usually if you're in the emergency room, it's going to be a pain crisis. It's going to be, an arrhythmia. It's going to be something, or stroke, things that need immediate treatment.
Yeah. Okay. Well,
I actually have a really funny story really quick, if we've got time for it.
Yes, we do.
So on the topic of women with Fabry disease, I was at Fabry camp in North Carolina. We weren't quite at the camp yet. We were doing the pre-meeting, and someone got ill. And so I went with her to urgent care. And I was in the middle of writing a lecture that I called Mythbusters, which was talking about, this is a myth we hear about Fabry disease in women, and this is how it's not true and why it's busted. And the urgent care physician comes in, looks at her, goes back out, comes back in and says, I saw that Fabry is mostly in men. And I said, funny you should say that. And I turned around my computer and I literally pulled up the slide deck that had all of these things that said, this is a chance a woman with Fabry disease will have this symptom. And this is a chance a woman with Fabry disease will have that symptom. She's like, oh. And he was so interested. And then he left the room and he came back. And he left the room and he came back because he wanted to talk about Fabry disease. So I feel like, unfortunately, part of a role of a woman with Fabry disease or a man with Fabry disease or a healthcare provider working in Fabry disease is educating in a good way other healthcare providers who, when you Google, something may pop up that says women may have symptoms, may have not, but telling them, yes, this is true. There are some very rare women with no symptoms, but that's the minority and not the majority. And that's where being a daily advocate can get a little tired, because you don't want to do that lecturing when you're in the urgent care for cut your finger off or whatever's going on. But I thought it was just funny because I was like, he's like, I've never seen Fabry disease. And I was like, there's a whole hotel of 300 people approximately under a mile from here. Should you want to come be educated with us? And he loved talking about it. He thought it was so interesting. And I think he's going to remember that forever. So
that is interesting. That's, it is moments like that where, it's when you're in that situation, it's hard to then think about how do I advocate for myself and what are these things I need to say. So I do think that, by having, certainly by having you there is that's the dream. But second to that, if you know some of these things that you can just say to help them understand how to help you, that makes the whole thing so much smoother. I was diagnosed at a young age. At that I was 15, but so at that time I was actually called a carrier. So how that came to be was they said, Julia may be a carrier or she may not. She may have symptoms. And if she does have symptoms, then that means she has Fabry disease. So that's how it was explained to me when I was 15. And then interestingly enough, I started having some symptoms. And then that was the day that they confirmed that I had Fabry. So it wasn't, it's very different today. And we're thankful for that, but I started going to meetings when I was, 15, 16, and I've sat through so many of them. But I remember when the first time I listened to you, and you had some, you make it really fun. You had some fine pictures up on the screen, but you do have a way of taking these complex things and simplifying them and making them really easy to understand. And so I think you have a gift, and thanks for sharing that gift with us, because it is so important, because part of this podcast is really about education. When you're educated, you have power. There's a lot of power in that feeling. And when you have that, you feel better. You can make better decisions. And, I think that what you're doing and your commitment is so important. So thank you, for everything that you do on behalf of all Fabry patients. And I want to close with, just one question to you. Now, on every one of our episodes, we're going to ask, what is one thing that you would say to Fabry patients about something they can do today to impact their life in a positive way?
Yeah, that's a great question. And, thanks for sharing your experience, Julia. I feel like the experience of women who were told they're carriers and then had to grow into having Fabry disease is really unique. I mean, how often are you told you're a patient in waiting?
Right.
And then you have to be a patient in waiting for therapy, depending on what the guidelines are. So it's unique. And the fact that you have, grown into this amazing advocate for Fabry disease, that you're working with that you're running the Canadian Fabry Disease Association. I'm in awe of you. And you got little kids and all these amazing things. So thank you for all your time and being such an amazing advocate for everybody, no matter where they live. Going back to your question, I want patients living with Fabry disease to consider Fabry's impact on the brain. So that would be your depression, the anxiety, just like any other organ. If you have protein in your urine, you might change your diet. You're definitely go see an expert, and maybe you'll start the medication. I want you to see that depression and that anxiety and the panic attacks the same way. Treat it like every other organ. It is there. Fabry is really making an impact on your brain. It is not that you're not mentally strong or that you should be doing something else or you're just going to power through it. Just like we would treat proteinuria, we should be able to treat anxiety so that you can do the things you need to do in your life. So that would be my thought, because I feel like sometimes mental health is so stigmatized, but there are experts that we can access, talk therapy, medications that can take the edge off or give you some things that you need, changes that you can do and techniques you can learn that can help you not be limited by what Fabry has done to how your brain works.
That is so great, because I think even saying that out loud, I think normalizing that, I think even if you're listening and you have Fabry or you're a caregiver, you're impacted so significantly that you can just be aware of that, starting with the awareness of just thinking, that I do have some of these things. And you know what? Most likely you do, because you're dealing with so much more on your shoulders, whether it's your symptoms or you're taking care of someone or you are keeping up with those, so many appointments. It's a lot, and it's a lot of additional things. So that then will cause extra stress and some extra emotions and some different things going on. And so I think that that's a great way a great tip, a great thing to focus on, and treat it just like we treat any other part of our body.
Exactly. And
Excellent.
as you know, with any other part of the body, if you ignore it too long, it starts impacting other things Like if you have anxiety, you're probably not going to sleep as well. You're not going to sleep as well. It's going to impact, your ability to tolerate pain and all the little difficulties and challenges you face in life, and your ability to handle those bills that come in. And if you just called the organization that helped pay for them, they would help you. But then it becomes like a big thing.
Yeah.
So, we all need sleep. We all need sometimes things that help us function just a little bit better. And we've come a long way. So there's a lot of virtual tools. I know that there's several health experts that you can access both online and in person, just depending on what works for you best. And you can kind of shop a little bit.
Absolutely. Well, thank you, Dawn. Thank you for your time, for your commitment, and thank you for being you, because you're making a difference in so many ways. So thank you.
Thank you, Julia. It's been great. I'll go move some papers. Bye, everybody.